So I think we have listened to very excellent talks, and I would like to add few things. The topic given to me is the shallow anterior chamber with small pupil, and as we know, there are different case scenarios with small pupil. I think, but the shallow anterior chamber and small pupil is a deadly combination, because once we have a case which has both, then it means that there can be associated zonular weakness in that case because PXF, inadequate visualization because of the small pupil, plus there are higher risk of iris prolapse if there is a shallow AC. There is a higher risk of aqueous misdirection as well as inadequate staining of the capsule, and risk of endothelial damage is there. So we have this combination to begin with. Now, first thing, how to decide whether I will be using iris retractors or I will be using pupil expansion devices in this case. So I use this simple test, I call it Sinskey test, where I just check for the phacodonesis before I begin the surgery. So I just go in with a Sinskey, touch the anterior capsule and try to see whether how much is the movement of the bag is, and accordingly I decide whether I should go for iris hook. So if the phacodonesis is quite severe, then I would like to use iris retractors, because in that case I want to see more of periphery in case it requires any more stabilization, or if I have to convert it into removal of the entire nucleus to scleral tunnel. So in that case, that is useful to begin with. Of course, you get fair idea when you start the capsulorhexis, but again, once you have started capsulorhexis, again putting a device may have little bit of difficulty. Now, generally for small pupil devices, this is an operated trap, very shallow anterior chamber, and I am going to stain the anterior capsule under the iris. So this is a very useful tip, because once you put the OVD, it's very difficult to stain the anterior capsule completely. So before you expand the ring, the capsule is already stained, so you don't have to worry about visualization of the capsule later. Now, whenever there is a rigid pupil, it's always best to do little bit of stretch pupilloplasty. Now, I don't do the limbus to limbus stretch pupilloplasty anymore, but I will do little bit of stretch pupilloplasty and then use a pupil expander device. So my choice is always B-hex, because it's thin profile and it works very well in these cases of shallow anterior chambers where already the working space is very limited. So my preferred way to put the B-hex is that I put the flange, subincisional flange under the iris, so it avoids getting trapped while you are injecting the IOL. Now for shallow antechamber and small pupil cases, many times we land up with very small CCC. That should be avoided. You should have adequate size of CCC. That is to avoid even later postoperative phimosis, and even the maneuvers are very difficult if you have very small CCC. Now we can remove the pupil expansion device under the viscoelastic before the visco wash, and then you can do a complete visco wash. Another way to do it is remove an entire viscoelastic, just put little bit of hyaluronate and then remove the B-hex and then remove the hyaluronate. Now this is another interesting case of nanophthalmos. The AC is extremely shallow, hardly 1.2 millimeter to begin with. You can see there are posterior synechiae. In this case, the staining under the iris is difficult because of the synechiae. So I am going to use a cohesive viscoelastic here so that I can remove it later easily. But here I used a dispersive OVD, which could have been avoided. So if we use dispersive OVD, then to stain under the capsule, we again have to use a cohesive underneath, or you have to wash the OVD and then again stain. So this is a very small cornea. This is a nanophthalmic eye and very thin anterior chamber. So in these cases also, my preferred choice will be B-hex. So after doing little bit of stretch pupilloplasty, it's better to do stretch pupilloplasty if you feel that the pupil is rigid, because if pupil is rigid, sometimes using pupil expansion device may be little bit of difficult. So with just 1.2 to 1.3 anterior chamber there, still I could use B-hex ring here because of its thin profile. Iris hooks is another way to deal it, but again with a small cornea and small anterior chamber, I wanted to avoid 4 more incisions and then using the iris hooks. Putting all the flanges properly before proceeding is very important. Now again here what I did, I tried to inject the dye under the existing OVD and could get good staining, but it's best if we use a cohesive OVD or remove the OVD and then stain it again and then put the OVD again. The in nanophthalmic eye, typically the lens bag is quite big, that is of good normal size, and here it was already an intumescent cataract, so I had double difficulties, but I could remove the I could do the CCC very well with use of good OVD and capsulorhexis forceps. Again, here there is always a chance of iris prolapse. I will show it in the next video, because whenever there is shallow anterior chamber, there is always a risk of iris prolapse. So in this case, I used customized IL of 57 diopters. But once we have the pupil expansion devices, good OVDs in hand, even in these small pupil cases with these difficult situations as well, we can achieve very good predictable results. So always whenever you have a case of shallow anterior chamber and very small pupil, be ready with all devices in hand. Use the best of OVDs so that you don't have issues. Again, as I was showing, for trailing haptic you have to be careful with BHEX, not to drag the BHEX along with that. Even if it gets dragged, just you have to make sure that it doesn't go into the capsular bag. Now, in this next case, this was a one-eyed lady, poor vision since childhood. Now, she already had adherent glaucoma since childhood, very shallow anterior chamber and mature cataract, and I had to deal with this case. So here, what is there? On nasal side, there is adherent glaucoma. On the temporal side, very shallow AC because of, I think, both because of the mature cataract and also because of the glaucoma there. So here I made a mistake. Just watch what happens. I have stained it under the iris, so the dye was trapped under the iris. So when I injected the dispersive agent, it got trapped. So what are the possible causes of shallow anterior the iris prolapse? One of the major cause is shallow anterior chamber, and also if you have made a very short incision, posterior incision, that can cause, sorry, the video has paused, and also raised IOP during the surgery. So make sure that you never raise the anterior chamber pressure during your procedure. Make it soft. And whenever you have any problems, always use the iris retractors or pupil expansion devices. So whenever there is iris prolapse, just find out what could be the cause amongst these and treat it accordingly. So here, what was the cause was when I injected the dye under the air, some dye got trapped under this iris because of the small pupil, and as I injected the OVD, which was a heavy dispersive OVD, this trapped dye had nowhere else to go and it started pushing the iris out. You can see the trapped dye. So here what is most important is that most common intuitive action is to keep pushing the iris back into the anterior chamber. That should be avoided. First thing is to remove the OVD from the anterior chamber, reduce the anterior chamber pressure, and that's what I am going to do. So I made 2 side ports here, another 2 incisions for the iris retractors, and then with bimanual I am going to remove the OVD. So I have used a heavy dispersive OVD here, so it's very difficult to wash it out, but you can see that dye trapped under the iris. The moment it came out, the anterior chamber pressure was down, and now I can push back the iris. So don't try to push back the iris if the anterior chamber pressure is still high. It is going to come out again. Now I am going to use iris retractors on both sides of the incision. Little posterior incisions were made. Maybe there was a need of one more iris hook. You can see on the nasal side, when I tried to put iris hook, iris retractor in fact went behind the iris because there was adherent glaucoma. Nonetheless, the whatever I wanted to achieve was achieved. Here, don't try to keep on pushing the iris back all the time. Use the side incisions to do maximum maneuvers during this case. So I completed the capsulorhexis from the side incisions there. Avoid hydrodissection in these cases, at least initially. Later, if required, you can do that because hydrodissection will cause further iris prolapse. Now, before inserting the phaco probe, just put little bit of heavy dispersive OVD over the iris and enter the probe, and try to complete the surgery without taking out the phaco probe. If you want, you can replenish the OVD in between through the side port incisions. So I could achieve a good phacoemulsification as well as irrigation aspiration. Whenever you take out probe in such situations, always make sure you stop the irrigation before taking out the probe. So there is little bit of hypotony which is achieved, and then you can remove the probe without much of the iris prolapse. Again, while injecting the IOL, you have to just make sure that the leading edge is not holding the iris there, so as to avoid any iridodialysis. Again, most important thing is to avoid temptation of keeping on pressing the iris back into the anterior chamber throughout the surgery. Just at the end, push the iris back and then suture it comfortably, and you will get a very good result post-operatively rather than trying to push it back all the time. So these were a few of my tips for shallow anterior chamber and small pupil
Thank you.
combinations. Thank you, sir.
Thank you, Dr. Saurabh.